Good evening. Welcome back. It's Julian Perez, Vice President of Risk Management Compliance with dentalcorp. I'm super excited this evening, to have with me a special guest, Dr. Brian Rittenberg. Dr. Rittenberg is head of oral surgery at Mount Sinai Hospital. He's also a partner and part owner of 3 oral surgery clinics here in Ontario, Crescent Oral Surgery. In addition, he's the former president of Ontario's Association of Oral Surgeons. We're going to talk today about emergency dentistry, about COVID-19, and what it means to be in this milieu. I'm really excited to be here with you, Dr. Rittenberg. Thank you for taking the evening and spending it with us.
Thank you for having me.
So, there's so much going on right now in the world. There's so much going on in Canada. There's so much going on in dentistry. Over the past 5 days, province by province, each of the dental regulatory authorities has ordered its membership, the dentists, to stop providing routine care, to stop providing elective care, and to only provide emergency dental services to its patients. This is an unprecedented moment in Canadian history and world history, and I want to talk to you a little bit about how it's impacted you and how you're going to use your experience to try to navigate this pandemic. If you could start by talking to me a little bit about what it means to be the head of oral surgery at Mount Sinai, I think that would be a great launching point.
It's a good question. And these are interesting times. I think, in regular times, being the head of oral surgery at a major downtown hospital in Toronto is it's interesting during regular times. So Mount Sinai Hospital's got a dental clinic, which actually services huge parts of the population, whether it be special needs dentistry, dentistry for medically compromised patients. There's an oral surgery clinic there, which is the home of the graduate program in oral surgery for U of T, University of Toronto. So there's general oral and maxillofacial surgery practice that goes on in our clinic. We also cover trauma for the hospital or cover emergency oral surgery services for the hospital, trauma, major infections, etc. And we spend a lot of time in the operating room doing elective maxillofacial surgical procedures. So lots going on.
So, talk to me a little bit about the different referral streams. I tend to think of going to my dentist. I go to a clinic, the professional that I know and adore, and I know the hygienist, and I know the dental assistant, and we have a social interaction, and I think that's what going to the dentist is like for a lot of Canadians. What is it like? How do people end up at the dental clinic, and how do people end up in the oral surgery department at Mount Sinai?
So there's a few streams. So some of the patients that come to the dental clinic and even the oral surgery clinic come through the same pathways you're talking about, whether it's referrals from dentists in the community to our group, the oral surgery group there, hospital employees that want to get their dental care taken care of. There's also a tertiary stream of referrals. So we'll see a lot of the more complex things that maybe oral surgeons in the community or dentists in the community can't handle or choose not to handle on their own. So there's sort of during regular times, there's sort of two pathways for patients to get to us.
Okay. And so one thing you mentioned was that part of the way people end up in the oral surgery clinic is through emergency triage, the emergency department. So this day and age, and I say in the last 48 hours, the number one question amongst Canadian dentists is, what is emergency dentistry? So I want you to rewind the clock all the way back to February. In February, if somebody were to say to you, define emergency dentistry or emergency dental services, what would you have said then?
I think in
How
general,
would you have thought about it?
Yeah, so very differently than we think about it now, which I know we're going to talk about.
Yeah.
I think, pain is a big issue. So pain's a big player in emergency dentistry, right? Things that by definition, emergency is sort of an unplanned event. Right. So whether it's a painful tooth, a fractured tooth, an infection, whether localized or systemic, facial fractures, lacerations, things like that would always be emergencies that we would never hesitate to handle during regular times in a hospital-based setting. I think now it's not that we can't handle those emergencies, and we certainly are. I think that the triage pathway is very different now.
Yeah, I think that triage is another sort of hot topic right now. So now we're in March. Fast forward to the third week of March, when things are all of a sudden very different in Canada. How has the definition of emergency dentistry changed? How has this landscape altered the way you think about the term dental emergency?
Yeah, so I don't think that the definition's necessarily changed. I think what's changed is the way we think about emergency dentistry, and more specifically, how we are triaging patients, whether it's at the hospital or in a private practice setting, to make sure that they're getting the care they need, while at the same time balancing that with, looking out for the needed resources in hospitals, right? So, whereas if we rewind again back to February before, where we would all tell you at Mount Sinai Hospital, we always love emergencies, and our interns and our residents would tell you they're happy to see emergencies, and our emergency department really would have no problem triaging anyone through the door with any dental emergency and contacting us. It's different now, and it's all based on resource management at the hospital, which I guess we'll chat about. I'm
hoping we'll get into that more. So I'm glad you brought up resource management, actually. There's been a lot of concern, I think, about, in general, just generally speaking, the ability of hospitals to take on an increased burden when we're dealing with a global pandemic. And I had a guest here a couple of days ago, and we were talking about the concept of flattening the curve, and that all of the things that we're doing this day and age, self-isolation, social distancing, observing, personal hygiene standards and all that kinds of things, they're really meant not at this point to stop people from getting COVID-19. They're meant to keep people from all getting it at the same time, because we have limited resources in public health. Our hospitals have limited resources, and we need to try to match the strain on those resources with their capacity. We've also heard, just in the best of times, there's been lots of debates throughout Canada about concepts like hallway medicine, and whether we need to invest more. We've got a generation of baby boomers now entering the period of their life when they start to use more of the public health system. Going back to February again, because I think it's useful to talk about the two worlds that we live in. Was there any concern at that point about the capacity of dental medical and dental surgical clinics in the hospital to meet the demand?
There were, I would say, at the level of patients who required more advanced care, operating room care, inpatient stays, inpatient beds. So it's not infrequently that I would get an email Tuesday, Wednesday, Thursday from our chief of surgery asking, not just to me, but to all the surgeons in the hospital, do you have planned discharges today? Because this concept of needing beds was always on the mind of everyone working in a hospital. Now we get to a point where this COVID-19 thing, we're at the beginning of it here. Right. And so if the curve can't, and I'm not here to talk about flattening the curve, but if the curve can't be flattened, crisis time happens quickly in hospitals. But at the best of times, resources are always on the mind of any administrator or anyone who's involved on an administrative level at the hospital. So that's one of the other things that I'm very peripherally involved
Right.
with at Mount Sinai is trying to keep our service in line with respect to resource management.
Yeah. So in the hospital, so is it generally, is the limited resource the human capital, the oral surgeons and their surgical teams, or is it more often the space in the operatories, or does it depend?
I'd say it's space, capacity, beds. Not so much not on our level. Like I think there wouldn't be a shortage of oral surgeons who would love to step up. And in fact, shout out to everyone who sent me a message this week offering to help at the hospital if we need help. And it's amazing where these messages are coming from. So I don't think there's a shortage.
Okay.
I don't think the resource shortage is on our end. I think it's the strain, the overall strain on the healthcare system. And I think it's just about to get magnified.
Yeah, I would imagine that's the case too. So I wonder if in the last few days, I think Ontario was the first province, the RCDSO was the first regulator to say, you know what, we're in a global pandemic situation. We can see that the number of cases of COVID-19 is starting to rise, and drastic measures are required. I think it was over the weekend, early in the week, that they essentially said there will be no more routine dentistry. What, for you at the hospital, with your we'll get into private practices, I'm super interested in that, but still at the hospital level, when you heard that happened, what did you start to think, and what did your colleagues at the hospital, and maybe if you're in contact with oral surgeons or dentists or specialists at other hospitals, what did the conversation turn to at that point?
I think very quickly it turned to how can we help from our standpoint.
Yeah.
I mean, I had a phone call on Monday with our chief of surgery where elective surgeries still weren't canceled at that point at Mount Sinai.
Okay.
And we knew it was coming, and he said it's coming Wednesday, and I said, like, no problem. And as long as those ORs need to be closed, I sort of understand the rationale behind it.
Right.
There was a bit of scramble mode, I think, within our group because the messages were coming out hour by hour, and they changed hour by hour over Sunday, Monday. But I think our team, Howie Tenenbaum's chief of dentistry at Mount Sinai Hospital, and I was on the phone with him a fair bit Sunday and Monday, and he responded amazingly well. And one thing that we did do is in concert with our chief of emergency medicine at Mount Sinai was figuring out a way to lighten the load on the emergency department.
Okay.
So what we did right away was what are the 2 or 3 emergencies that really need to be seen through the emergency department, need to be triaged by a nurse, maybe seen by an emerge doc before they see our service.
So we're talking about people show up in an ambulance, show up recent trauma.
Yeah, or walking off the street or what have you. And we really very quickly were able to limit it to 3 emergencies.
Okay.
I don't know if you want to talk about those now.
Yeah, let's get into it right now. I'm super curious what those are.
So really what we figured out was the 3 emergencies that definitely need to be seen and should come through the emergency department would be any sort of significant facial trauma, presumed facial fractures, any severe infection, odontogenic infection with potential systemic involvement or space abscess, so bad facial swellings, things like that, and uncontrolled bleeding. Right. Really. So we said, let's take this group of 3 emergencies, and those are the ones that, unfortunately, with respect to resources, those are the ones that hopefully will be a very minor drain on resources, but we need to lean on the emerge department for those. And then we said, all the other emergencies that from February, and if you go in reverse, for time,
the old definition.
Yeah, the old definition, and hopefully one day the new definition. Or we'll return to that. But all those other emergencies, even the intractable dental pain where there's no obvious sign of systemic infection, fractured teeth, pulp exposures, things like that, would be seen. We would sort of set up a dental emergency clinic within our dental department at Mount Sinai, and we would triage those patients to determine if they were actual emergencies that needed to be seen here and now.
Okay.
So that was one of the ways we thought we could help, and that was our first sort of thought is, on a daily basis, a normal daily basis,
Right.
our dental residents, not even the oral surgery residents, the dental residents are called to the emergency department, I would bet, probably 15 to 20 times a day, maybe more.
And what are the 3 or 4 things that they're most often called for?
Not the 3 biggies.
No, it doesn't sound like
right?
that, yeah.
Not the 3
Okay.
biggies, right? So it would be intractable pain,
Right.
fractured teeth,
Right.
pulp exposures.
Ouch.
Things
that
that
sounds very painful.
painful.
I'm calling that an emergency in February, and
They're-
personally,
They're
I'm
emergencies
feeling
now.
like it's an emergency now. Exactly.
They're still emergencies
Right,
now.
right.
The way we, and we'll chat about
But are they
as we go on.
life-threatening? That's where. So you were more getting at these are the life-threatening situations.
Potentially, yeah.
Yeah.
So, and I think the messaging, the big message to the emergency department,
Right.
from our standpoint, was
Right.
we want to help. We don't
Right.
want it. We don't want to bring down resources. We want to help.
Of course.
And so this is becoming the new normal.
Mm-hmm.
It's been 2 or 3 days now that this has been going on, and I hope that it will be of benefit.
Yeah.
I think there's a lot of things that can still be done, even at Mount Sinai, or any dental clinic in a hospital or private practice.
Yeah.
Where the other thing we can try and do is manage patients without even seeing them. I mean, because that, to me, during this
Right.
period of time,
Right.
is probably the most beneficial thing we can do.
Well, we're going to get into that. I think we're going to get into a whole series of questions where patient calls up with symptoms, and we'll see what you say.
Okay.
And you might have to put a little bit your general dentistry hat
No
on
problem.
for some of those. And I also want to pause here, because I want to come back to the hospital later.
Okay.
But now I want to talk to Dr. Brian Rittenberg, partner, part owner of a group of oral surgery clinics, private dentistry. And let's first explain to me maybe your stream of referrals or where your patients come there, and then we'll start talking a little bit more about what that means in the time of
Okay.
emergency-only dentistry.
Yeah, so in general, I would say the majority of our patients are still referral-based patients.
Mm-hmm.
So from general dentists in the community.
Makes sense.
And that includes, majority of it's elective stuff where patients are booked for consults and they come for a consult and we book their procedure after that. But there's still a fair bit of emergency surgical
Sure.
management that we do in the office on
I
a
would
daily
imagine.
basis. Again, whether it's same things, fractured teeth,
Mhm.
unrestorable teeth that require extractions, infections, and those sort of things.
Mhm.
But I'd say the majority of it's still referral based, not all of it.
Okay.
Not all of it.
Okay. And so who generally is referring to you? We're talking general dentists, other specialists, a combination.
A combination. Majority probably general dentists, endodontists, because they see, they'll see a lot of patients
Yep.
where there may be a non-restorable tooth.
Sure. Yeah. There's
that
the
they'll
endo,
refer to us.
retreatment,
Yeah.
and then what's the next step?
Yeah, exactly. It's a combination, but I'd say the majority are still general dentists.
Okay.
referring.
And now, I want to go back to February, a long time ago, or even March 1st.
Seems like a long time ago.
It seems like forever ago. It's March 1st, and the definition of emergency for you. So it could be a general dentist, or it could be a self-referral patient. What is your thinking around emergency dentistry as a private oral surgeon practicing in Ontario?
I mean, I think for us, for our group, and probably for most oral surgeons, our number one priority is obviously the patient, and number two is to support our referrals.
Right.
So our policy in our practice,
Yeah.
the referral picks up the phone and calls and says, I have a patient that's an emergency.
Okay.
We see that patient
Right.
that
So
day.
I'm extracting a wisdom tooth, general dentist, and all of a sudden there's oral antral communication.
Yep.
I've explained it to the patient, and they would like to see an oral surgeon. That's an emergency.
That's an emergency.
That's emergency in February.
Yeah.
Okay.
Now?
Is it emergency today?
Well, I would say today,
Yeah.
that general dentist shouldn't be taking that wisdom tooth out right now.
Okay.
Right? So that's the first
Well,
that's the first major difference in what's
Okay.
going on.
Okay.
But I understand what you're saying.
Sure.
Yeah. So I would say then pre COVID-19,
Right.
we had, and we still do have an open door sort of policy or open phone policy where you need us, you call us. And I don't think that's unique to Crescent Oral Surgery.
Right.
I would hope it's not, but that's our policy.
That's a typical Canadian model for oral surgery groups right now.
And then the other group of emergencies are, we do a lot of surgery in our clinics.
Right.
And we have 24-hour, 7-day-a-week emergency coverage. So
Yep.
one of the 7 of us in the group take a week of call at a time.
Okay.
So the office phones turn off at 5 o'clock.
Right.
My phone turns on.
Okay.
So I might get a patient whose wisdom teeth were taken out by one of my partners or by me earlier in the day who's got some bleeding that's poorly controlled.
Right.
I might have a patient who we placed an implant a month ago. They've got some new swelling, infection. A lot of that, I would say 99% of that, we still manage by phone.
Okay.
Right. So it's
are we talking about
we're
pre-emergency,
So I'm saying even pre-COVID, where we are, let's say in February.
And how do you manage it by phone then? Let's play this out a little bit. I don't know if you do all on 4 or all on 6 or so. I have a full clearance and I've got some implants in, and one of the surgical sites is painful. It's swollen. Maybe there's a little signs of pus. And I call in and I say, "Doc, help me out. You did the surgery. What should I do?" Or maybe it was one of your partners. Help me out. What's the conversation look like there?
So the big questions right away is you're thinking, is there a systemic or significant component to this infection?
Right.
So do you have a fever?
Right.
Yes or no, right? Is your swelling externalized? Is your cheek swollen? Is your neck swollen?
Okay.
If the answer to those 2 questions are no, and some of the other things you might ask, typical kind of ways to suss out whether or not someone might have a deep space infection or abscess. You having trouble swallowing? Are you having difficulty opening your mouth? If the answer to all those questions are no, then I would likely, if this is, let's say, an evening or a Saturday or a Sunday, I would likely, if it sounds like there's an infection, start the patient on some antibiotics.
Right.
Control their pain. I would try and control their pain with over-the-counter analgesics, anti-inflammatories, Tylenol-based analgesics.
Right.
And I would book that patient in the first opportune time. So if this is Sunday afternoon, I'd say you're going to come see us Monday at 8 a.m.
Okay.
There are times where where any of us will go in and see a patient after hours at the office. But it's really rare to need to do, in 17 years of practice, I've done it about 4 or 5 times.
But even, so just getting back to, and I don't know if it's semantics or if it's point of reference, but on Monday morning, when that patient comes in, back in February, you'd probably call them an emerge visit. And I don't know, we're not going to get into procedure codes or anything like that, but this may be, if it wasn't your patient and they came in with the same symptoms, you would consider that an emergency dental visit.
Yes.
Yeah.
Yeah.
So now let's fast forward. Now we're 3rd week of March again.
Okay.
So patient calls on Sunday afternoon and they say, I had implants done at another clinic. It wasn't your clinic. I don't want to go back to that clinic. I want to come see you guys. Self-referral, and they're saying, here's my symptoms. I have 6 implants in. One of them hurts a lot. It's a little bit swollen. It's super tender. It's a little bit of pus. Coming in for my emergency dental visit. Are you asking any different questions now?
Yeah. So I don't know if we're gonna probably talk about active screening questions.
We're going to get into screening and all of that soon. But
so
that
besides that,
we'll stick with emergency.
Yeah. So the first thing I would tell everyone, and it's not that I don't want to see this person as a patient, is I would strongly encourage them, unless they had really good reason, to really be in touch with, at the very least, whoever the practitioner was that rendered treatment.
Yeah, your referring dentists are happy to hear that.
Yeah, I mean that's what I would want, right?
Yeah,
so any of my patients, whether they're happy or unhappy with what I did for them, if there's a problem, I'd want them to call me to deal with the problem.
Right.
For whatever reason, this patient says, I don't want to call that.
That was a great disclaimer. By the way, I just want everybody to know I wasn't taking the patient's side. Okay, I think the original dentist who did the surgery was probably a fantastic practitioner. I was just proposing a scenario.
Yeah. So this patient definitely doesn't want to go back. Right now, what I would do,
Yeah.
again, if I don't think that there's a systemic component or
Yeah.
significant component to this infection,
Right.
After ensuring they've got no allergies to whatever antibiotic I want to put them on, is I would start them on an antibiotic, and again, I would, and probably some chlorhexidine mouth rinses, and get them on an NSAID and some Tylenol, and I'd want to reconnect with them about 48 hours later and find out how they're doing. And I'd let them know if they get worse, if they develop any of those signs of systemic or significant infection, they're to call back beforehand. If in 48 hours they say they're doing better, right now, in the third week in March,
Right, today.
I'd say, we're going to book you on the other side of this. And if this becomes a problem again, before we can reopen our offices to reestablish, normal treatment patterns, then you call us back again.
Okay.
And I think that's probably the most responsible way. I'm not talking about necessarily, one of the, I think, things we have to juggle now is
First of all,
yeah.
Okay, I just want to say remember what you're about to juggle.
Yeah.
Okay? But I do want to say this at some point. Just to be fair, you're speaking from what authority?
So we spoke about this before. This is not intended to be authoritative in any way. I'm speaking to you, because of my position at the hospital and within our group. I think my private practice. I felt like I had the responsibility to really study this, to study, Toronto Public Health's guidelines, the provincial ministry, the federal ministry, the CDC's documents, the WHO documents. And so what I'm talking to you about is my consolidation of this information.
Your experience, your expertise.
This is not authoritative, and I encourage everyone actually, and I'm sure you all have, to take the time actually. We're sitting in front of our computers. I'm finding like 90% of the day now.
Yeah.
Surf some of those sites because you get a lot of really good information, and it changes. It actually changes hourly, some of these websites and the information that's coming out. So
yeah, it does.
So yes.
So you were juggling a minute ago. There were some symptoms.
Right.
You were considering possible pharmacological solutions, and you were juggling.
So the big juggling act is, textbook treatment of a patient versus what we're doing now to make sure a patient is managed appropriately, maybe not in the textbook sense of management, but also making sure we're being socially responsible. And so me dragging that patient to my office that you spoke of takes them out of the environment that everyone who's talking to us from all those sources that I mentioned are telling us not to do. They're saying stay home.
Social isolation, social distancing.
Stay home. And so it is a real, it's I think the hardest thing in speaking, all the dentists I've spoken to in the past 3-4 days, that's the toughest thing I think people are struggling with. Is like, I know what the right thing to do is pre-COVID.
Right. It's a different world now.
It's very different. And I think as long as...
States of emergency.
Yeah. So I think as long as we're making sure that a patient is being managed, I think the worst thing that can be done is someone who shutters their practice, turns their phone off, and says, we're not supposed to be doing anything, because that's not what anyone has said.
Yeah, absolutely not. So, so still in private practice then, the way you think about emergency, I think that those vignettes you just shared or scenarios we just discussed were really helpful in how the thinking has changed. What else has changed in private practice? Have you received any calls from your referring dentists asking you any kinds of questions, I suppose? Are you still open? Do you have capacity? What should I do with my patients who, are emerge? And how, I don't know, have you been getting kinds of questions like that?
We have, and we sent information out to our referrals to let them know that in fact we are open.
Good.
And we're open to the extent that the RCDSO has told us to be open, which is we will manage all emergent, non-elective patient problems that present.
Right.
But we're also encouraging our referrals to also try and manage some of these things too, right? Because what'll happen is if everyone shuts their doors and leaves it to whether it be oral surgery practices or hospital-based or endo practices or what have you, I think they're going to get overwhelmed. And so what we all need to start doing is taking a page from our medical colleagues who have always done a lot more. It's really hard to do telehealth in dentistry.
Right.
But you can manage a lot of emergencies via telehealth.
Yeah.
And I think we need to take a page from our medical colleagues who have always practiced a lot of telemedicine,
Right.
but since this started have been encouraged to practice telemedicine. There are some significant differences, I think, financially.
Sure.
Where there are financial resources available to medical colleagues for practicing telemedicine. There are none for us. But at this point, I
So
think
let's talk about telemedicine, because generally speaking, I think this goes for physicians as well as dentists. When you call the clinic, and this is back in February, you don't speak with your family physician or your oncologist necessarily, or your dentist or your oral surgeon. You often speak with a treatment coordinator, a receptionist, a practice manager, could be a dental assistant who has multiple roles. Now that we're in the era of regulatory advised and mandated teledentistry, what's changed about private practice? Have you been training and coaching staff, or are you answering the phone more often, or a combination?
We're not answering the phone, the surgeons in our group. We have done, again, pretty rapid training for those nurses and dental assistants working in our practice now, in teaching them how to triage over the phone. And the protocols we came up with in our practice, which again they're Crescent Oral Surgery's protocols. Everyone's free to use
patented?
them.
No, okay.
No, but I mean, I'm not saying this is what everyone should be doing. But what we're doing in our practice, and we took a long time to sort of work on this on Sunday, half a day to figure them out. If a phone call comes in now, because keep in mind, I'm going to backtrack a bit.
Let's backtrack.
If I'm working in the office tomorrow, if I'm the surgeon covering our office tomorrow, we're doing it one surgeon a day, there's not a lot going on there. So whereas 2 weeks ago, I can't be on the phone all day talking to patients.
Right.
But now, if our nurse feels that there's someone who might need anything more than some reassurance that they're going to be okay, really for the most part.
Rinse your mouth with salt water.
That sort of stuff.
Yeah.
They've actually been told if there's an emergency call that comes through, our protocol is I get an email sent to me at my desk.
Okay.
I'll respond to it. I'll practice telemedicine.
Okay.
I'll decide after speaking to the patient if they need to be seen.
Okay.
If they need to be seen, they're going to get appointed and they're going to come into the office.
Okay.
So that's how we're doing it in our practice. So the answer to your question is, yeah, we're doing a lot more speaking to patients now.
Okay.
In the past, if I was covering emergency call for the practice, our answering service would provide me with patient's phone number, and I would speak to the patient directly after hours. During the day, our nurses would typically deal with most of the calls that came in. And if patients needed to be seen, they're really excellent at triage. They would bring the patient in to see us.
Okay. So there are right now two different streams of triage in dentistry. We've talked almost exclusively so far about emergency dentistry because that's all anyone is doing in Canada at the moment. So I think it's extremely interesting and valuable to talk about what that means. And it might mean something different to different specialties. To general dentist versus an oral surgeon, you have a very specific vantage point in dentistry where you've been, and you may be even biased towards the more extreme side of emergencies, having worked with your emergency medicine colleagues and then taking on some of their definition of a true emergency. So I think we'll come back to emergency, but I want to talk about the other level of triage that's come into force in the last few weeks and months. That has to do with COVID-19. So there was a crash course, you were saying, with some of your staff about emergency protocols and what that means post March 15th or 16th. What other kinds of questions now are the people answering your phone or responding to emails or responding to referrals? What other kinds of questions are they asking?
So I think if we determine a patient maybe should be seen in the office,
Okay, yep.
then we're obligated to actively screen them for COVID-19 twice, once on the phone
Okay.
and once when they come into the office. The active screening questions, they're all available if you go on Toronto Public Health and Provincial Ministry, and probably on the RCDSO website is my guess, because there's a link, I think, to Public Health. And there's really 4 biggies, right? So the big questions are, do you have a fever? Do you have signs or symptoms of respiratory infection? Have you traveled outside of Canada in the last 14 days? And have you been in contact with anyone either COVID-19 positive or presumed positive?
Okay.
And if the answer to any of those questions is yes, you fail active screening.
Okay.
That doesn't necessarily mean that patient can't be seen in my office, in an office setting. But it will make me really try my hardest to manage whatever's happening via telemedicine, number one.
Okay.
And number two, if that patient hasn't reported to public health, they should.
Okay.
And I think that's our duty as dentists, is to ensure that patient is told that they have to report to public health. There may even be a duty that we need to report them. This is the non-authoritative part of this.
Yes.
I'm not sure, to be honest.
Okay.
So
I won't make you take a position on that, but let's just say best practice, or it's worth informing the patient that they should contact public health. For sure,
contact public health. If I think they still need to be seen, and I have appropriate personal protective equipment in my office, which we're going to chat about soon.
Absolutely.
Then I would see them. I would see them in the office.
Okay.
If I didn't have appropriate PPE, then we will chat about what some alternatives are.
So let's go back to February.
Yeah.
So somebody says, listen, I have the sniffles, I got a bit of a cold, but I also have this infection. It really hurts and I can't sleep. You say, okay, listen, let's take a look. Let's see what it is.
Yeah.
You get to work. Are you at this private practice? You're probably expecting to do surgery. You know, I imagine, you've got the referral information, x-rays, maybe some information from the general dentist about presenting symptomology or the history of treatment, and you're probably ready to do surgery, ready to put on your PPE. And so now, are you going to work? Are you thinking something differently? Are you thinking maybe, can I avoid surgery here, or what's the mentality?
I think, if at all possible, you want to avoid seeing the patient if at all possible.
Step one.
And step two is if you can avoid any surgery that will result in some aerosol being released, which is, quite frankly, probably most things in dentistry and for sure oral surgery.
Okay.
You want to try and prevent having to do that.
Right.
And if you don't have appropriate PPE, you shouldn't be doing any of that stuff on that presumed positive patient.
Right.
Now, going back to before this all started, back to February, I mean, I haven't missed many days of work. We all go to work with colds, right? So that's the hard way. We're having to wrap our heads around this. Wait a sec. Now if I get a cold, I guess I should, like, this is before Sunday when the RCDSO told us
it's not just you,
work.
Everybody in Canada goes,
last week,
minor
2 weeks
sniffles.
ago, we were saying, if I get a cold, what am I going to do? I probably shouldn't be at work. People are going to be uncomfortable.
Probably shouldn't.
Right?
But now
now there's a new normal, right?
Yeah.
And where it's going to be after this, I don't know. But for the foreseeable future, this is like the new normal. So yeah, anyone who fails active screening, I would try my hardest to not I wouldn't say not see them. To consult them again, if you have appropriate PPE, and we got to, we got to take some time to really, because there's some huge misconceptions about that.
Very into the weeds on PPE. It's gonna be some insider baseball for sure. So don't worry about that.
But yeah, trying our hardest to not render treatment if not required.
Yeah. Okay, so I'm just gonna put you in a situation where you are on the fence.
Okay.
You don't know if this patient needs to be seen urgently or not. But you know they are COVID positive. You've decided I'm going to have them in. Are you going to do anything differently during the examination, for example, or are you then going to consider, can this person be seen at a hospital or can they be somewhere else? Like what now? It's yesterday, and our CDSO's mandate has come down, which it has from coast to coast. This patient comes in. They have minor fever, but they also have significant swelling. You're starting to be concerned.
Right.
So you see them. Hello, I'm the patient.
So this is the biggest challenge, right?
Yeah.
Is they're febrile, they have a fever,
right,
but they have swelling.
There you go.
Right?
There you go.
Is the fever viral? Is the fever related to their infection? And we're going to get this.
Yeah.
And
absolutely.
I haven't been on call at the hospital
and you're going to get that too.
But I'm sure that's happened. I think now we have to assume right now that fever is probably viral. I would just say, just to be overly cautious, I would treat that person based on those active screening. Right. It doesn't say, do you have a fever and not a dental infection, right?
Good point.
So I think I would read it, and I don't think there's any harm in a false positive on an active screening. Right. I think where the harm comes in a false negative.
Right.
So the way that our office is flowing now is after the active screening on the phone, let's say it was missed on the active phone screening, patient comes in, we have our greeters in full PPE. In other words, they are gowned, they have eye protection, they have our greeter at the office.
Wow.
The person doing the active screening
Is
in
this February?
Office. No. This is now. So they have a surgical mask on, eye protection, gown.
The only person walking in that door is an emergency.
And they've been screened. No one's coming in off the street without us knowing they're coming.
And so when they come in, you already know that you've got a potential COVID-19 positive patient.
Or even if someone who screened negative, they passed active screening.
Right. You're still
they come
prepared.
in. So even, I'm going to backtrack. They're also given a specific appointment time to minimize overlapping patients in the office. They're also told they can only bring one visitor with them who also has to pass active screening. Right? So they come. Good. So this patient somehow passed active screening on phone, comes in with a fever, a bit of swelling. I would treat that patient now as being potentially COVID positive.
So when you say so how do you know they have a fever? At what point are you taking their temperature? I guess is the question I'm asking.
So if so it's a good question. Their temperature isn't. I don't think we're taking everyone's temperature at the door. But if someone feels unwell when they come into the office, their temperature should be taken. Now, if we go back to SARS, right, where I was finishing my training, it was in the last year of my surgical training, and I remember at Toronto General Hospital having to walk through a trailer at the beginning of every day where you'd have your temperature taken.
Right.
You'd have active screening questions done.
Wow.
They'd put an N95 mask on you.
Okay.
If you didn't have a fever and you passed your screening, you get a mask and you wore it the whole day. The hospitals,
same mask?
Same mask the whole, well, unless you were treating patients, and then between patients you would change your mask.
Okay.
Right now, the hospitals, as far as I know, are not taking everyone's temperature. In fact, I know that me as a staff member at Mount Sinai, I have to show my badge to get into the hospital.
Wow.
And what the hospital has said to all of us, if you're showing your badge, you're essentially telling us that you're passing active screening.
I've screened myself.
Correct. So, that patient who comes in, hopefully they would tell us, because hopefully people are kind of a little bit more self-aware now that I really don't feel well and I feel like I have a fever. I would take our greeter would then take their temperature.
Okay.
And that's why those greeters are in the full assumed COVID-19 positive PPE, because they're actually doing an active screening. So they're not sure if that patient coming in is positive or negative. If they're positive, the patient gets a mask.
Right.
The way that and gloves, the way that our office is set up now is no one's hanging out in the waiting room. You're going straight to a treatment room or consult room. And me as the surgeon, I would go in, if I'm doing a consult on this patient, with universal PPE. So not an N9. This
Class
is the
3,
whole,
maybe.
right, but not an N95 respirator.
Right.
I would probably wear a gown, although if you read, you know, the ministry's website for ambulatory or outpatient care, it doesn't. It's a little ambiguous
They've
as
got
to
a
whether I need a gown.
table
Right.
with a decision tree about what kind
This
of
is
PPE
for
to wear.
purely consult
Sure.
purposes
Yeah.
on someone who's assumed COVID positive.
Okay.
If I determine, hopefully the patient needs nothing but a prescription,
Right. You're relieved.
they're going to go, they're going to leave, and that room will get appropriately wiped down.
Right.
And any touch
Turned
point or touch surface that they've come in contact with.
Right.
If they need treatment, that's a whole different story, right?
Okay.
That's when you get into the need for face shield versus eye protection, N95 respirator, appropriately fitted, versus surgical mask.
Let's do it now. Let's get into. I think we're gonna bounce around a little bit, and that's okay.
That's my fault.
Yeah, no. Everybody. So I think there's 3 things that everybody is dying to know in dentistry. One is emergency care. The other is screening for COVID, and the third is what am I supposed to wear now for treatment? Okay.
Yeah.
So, patient comes in, examination, screened positive for COVID. You just said you're going to wear as much PPE as possible, but in terms of the mask, a class 3.
For a consult, for an examination purpose. No aerosols,
Right.
I'm just looking in their mouth, I'm examining them. Yeah, I'd wear a surgical mask.
Okay. So, let's go back and talk about an emergency patient that came in who screened negative. Let's start with same patient came in. I'm going to change the facts a little bit. This time, she has no fever.
Okay.
Bacterial or viral.
Okay.
Might have taken Tylenol, I don't know. But in any event, she's got no fever. She feels fine. She passed all the other questions. Turns out there's a significant infection there. It's complex, impacted, third molar procedure. Her general dentist referred her to you, and you're going to do that surgery. Talk to me about PPE for you, dental assistant, for patient, for your greeters.
Okay. So, and this is pre-COVID or now, right here and now?
Let's do both, because I think the distinction helps and the change helps. So
I would say pre-COVID, our greeter at the front desk is in no personal protective equipment at all.
Right.
For the purposes of a consult, for me to evaluate a patient, I'd wear a level 1 mask.
Right.
You can wear a level 3 mask if you want, and the difference is really particle size and what's allowed to pass through these masks. But you don't necessarily need a surgical mask. You need a mask for a consult, and gloves.
Okay.
Right?
Yeah.
For a consult.
Right.
If I was rendering treatment for that patient, gown, eye protection, surgical mask, level 3 mask. Right? That's pre-COVID.
Yeah.
Now that same patient comes in, and we're assuming that I have to render emergent care, so I have to, drain a vestibular abscess in my office and do something on a COVID negative, someone who passes active screening. Universal PPE, eye protection, gown, surgical mask, gloves.
So finally, something that hasn't changed that much.
That might change, but that hasn't changed up until now. The COVID positive or presumed positive or patient who fails active screening is different.
Before we get into that, can we just say one more time that universal PPE has not changed?
It has not changed.
A lot of dentists across the country think that for anything more than an examination, automatically you have to wear a respirator, N95 or higher.
So there's a couple problems with that.
Okay.
Is that I would venture I could be wrong, but unless you're on staff at a hospital or have had some reason to have, as we talked about before this session started, to have a mask fit test done.
Right.
You don't know what N95.
I had heard
there's-
fit test 3 days ago, by the way.
Yeah, fit test. There are, I don't know how many, but there are a number of different N95 respirators or masks. And if you aren't fit tested and don't have the appropriate mask on, number one. Number two, if you're not trained in how to don and doff the mask, take it on, put it on and take it off. And number three, if you're not clean shaven, an N95 respirator, I won't say is useless, but it's definitely no more useful than a surgical mask.
So are you shaved enough right now?
No.
Okay.
So tomorrow I'm starting a week on call at the hospital, and if I'm having to operate on a patient who fails active screening, I will definitely have to shave because I'll need to wear my N95, my properly fitted N95 mask.
So this is just pure curiosity. Is there like a shave kit at the hospital, or do you have to? I'm just curious.
So my last mask fit test was done, I don't know, a year and a half ago. They're good for 2 years. And I went to the mask fit test. This has nothing to do with COVID, but this is a nice light story to lighten the mood a bit. And I went to occupational health for my test, and they looked at me and they said, "You need to shave." And I said, "No, I don't." They said, "Yeah, you need to shave." A little bit of an argument.
Okay.
I said, "Fine." So for the first time ever, I actually went to one of these old school barber shops on Dundas.
Oh, nice.
And I had a straight blade shave.
Wow.
And I went back and got tested. So you actually, there are some really awful razors at the hospital that none of us would ever want to use.
Okay.
But you do need to be clean shaven.
Yeah, and it's interesting. If I'm gonna have to get a shave, I'm gonna go get a whole experience.
Even a shadow. Like so, some of our residents went for their testing a few weeks ago, and they were sent away to come back completely clean shaven.
Wow.
So that's the issue with N95s in a general dental, or even an oral surgery, endo, perio, even any setting where you have not been appropriately fit tested, you probably shouldn't be rendering any active care to patients who fail active screening at all, because you cannot reliably wear an N95 respirator or mask. But that doesn't mean that you can't see the patient for a consult.
Right.
It doesn't mean you can't, if they can be managed non-surgically, manage them non-surgically.
Diagnose.
Right. And so that's where that's the biggest misconception, and that's one of the issues I think that will put a strain on the entire system now, whether it's the endo practices, oral surgery practices, or hospitals. Because a lot of these patients don't need active treatment right now. And so they don't need to get into those settings and can be managed in their initial point of contact. And so I think that's critical. Yeah. That's really critical.
So I'm going to talk about another piece of PPE. We're going to come back to the N95. That is the word on everybody's lips right now. What about shields? Is this something that's common in the OR? Do you use it in private practice for surgeries?
So pure face shields, they're available in the OR to be used. I personally in the OR don't. I wear protective goggles in the OR. We wear goggles in our practice. But I think, again, it's different now with a presumed positive, COVID positive patient or someone who fails active screening that you need to render treatment to that could release aerosol. Right. Then a face shield is required.
Okay.
Yeah.
You're taking all precautions then, essentially, at this point.
For you, for your staff, for your nurses, dental assistants, whoever might be in that room with
anesthesiologist, if you have one.
Yep.
Okay, so in private practice, I'm not sure that you've been trying to procure N95s, but I can tell you that across the country and globally, they are a precious commodity. Has there been any talk about potential shortages? I want to go back to wearing your hospital hat as head of oral surgery at Mount Sinai. Has there been any concern about the supply chain for hospitals?
There definitely has been. And one of the things that always that happened in SARS and happened again now is at the onset of these, masks go missing. Suddenly masks walk. And so, and
they go home with people.
Huge theft, right? So they've all been now locked up. The answer to your question is, I think in private practice right now, we're at sort of the bottom of the list of people who are able to sort of get their hands on these N95 masks, because the frontline healthcare workers in hospital are really the number one priority.
Yeah.
That will probably change as this goes on, because this is going to go on for a while.
I think the demand for masks globally, from what I can see in Europe, North America, and eventually, other parts of Asia, like you haven't heard about COVID in India yet. It's a large population there.
Yeah.
Africa hasn't been a huge thing. That's a large population of people there. I don't see the demand going down for a little while.
No.
I don't know if you've got a lot of connections in the medical supply world, but are you thinking that this shortage could last? I mean, at the hospital, it's one thing. The government's going to fight for you.
Yeah, I think the answer to your question is I'm not sure. My guess is that whoever's producing these has probably ramped up their production. But I do know, like, for example, today our head clinical nurse made a call to see about buying more N95 masks.
Yeah.
And was told that's an impossibility right now.
And this is at your
This is at my private
practice.
practice. In the hospital now, they're still available, obviously in the emergency department, in the operating rooms, in clinic settings as of now. But the big problem with, and this is the other issue with flooding hospitals, and even though, at Mount Sinai we've set up this system where we have the capability to manage the non-emergency room emergencies, is that at some point, the emergency department, the ORs, may say, we need that supply of N95 respirators for our units.
Yeah.
They may dry up for a clinic like the dental clinic or like any other clinic in the hospital. For now, we've got them.
Right.
Everyone who's working there has been mask fit tested appropriately. So the PPE, there's no PPE issue currently.
Right.
But that, unless the
depends
supply
on
chain,
the curve,
yeah,
on how the duration,
right,
and also the supply chain. Because the other thing is that, when we're talking about supply chain, let's imagine, for example, that all the masks are made in Italy. They're on lockdown.
Yeah.
Nobody's going to work. So this is a multifactorial situation. But in private practice, I've been hearing from a number of dentists, a number of suppliers, exactly what you just said. That getting an N95 is an impossibility. By the way, did your nurse tell you when it would be a possibility?
We got no answer. She, as far as I know, she did not. There was no date given to her. But again, the issue is, even in a practice like ours, our nurses haven't necessarily, like all the surgeons, because we all work at hospitals, we're all appropriately fit tested.
Right. What's your size N95?
I think I'm an 8610. I can't remember exactly. I've got it in my wallet. But
They know at the hospital for sure.
They know at the hospital for sure. But that's the problem. Is like, so if someone needs treatment, my nurse, if someone's COVID positive or fails active screening or all those things we talked about, our nurses and our dental assistants haven't been fit tested. So it comes down on, me and maybe one of my partners acting as an assistant to treat these patients, if we can get our hands on the appropriate N95.
Which right now you can't.
We have like maybe a box at each of our locations. We don't have a lot.
Right, 20 in a box or something. That's 10.
And they've probably,
if you only have two, a surgeon and an assistant, 10
cases.
Procedures.
And they've probably been on that shelf like for a long time.
Yeah.
Right? So
yeah, you might want to just dust them off at this point. They're a fairly precious commodity. Just acknowledge them and thank them for being there. Yeah, I would lock. They might not be there tomorrow. I'm sure your staff is fantastic, but I mean, wouldn't be unprecedented. So, apropos of this conversation, a whole bunch of regulatory authorities recently have started reaching out to the clinics in their provinces. Ontario is definitely one of them. I believe Alberta, I believe BC. A number of the provincial regulatory authorities have been asking dental clinics, are you prepared to treat the emergency COVID patient?
Yeah.
The double. We've double screened. Are you prepared for that? So I think the conversation we just had probably answered this question, but did Crescent Oral Surgery raise its hand and say, send them our way?
So to be, in all honesty, I read that for the first time today when I was just doing a bit of my
It's been
final
up
research
for a
this.
day and a half.
I know.
Where have you been?
So we probably will add our name to the list,
Yeah.
but I do think that list. Now, listen, I don't know.
I'm not putting pressure on you,
No, no,
by
no.
the way. I'm just curious.
I don't know if the definition is going to change. I don't know if public health's going to say, I get that maybe you haven't been mask fit tested, but any N95 mask will do. I don't know. But as of now, as far as I know, sort of the rules surrounding the use of those respirators is, my guess is that list of people saying, I'm prepared to manage a COVID positive patient is going to be really small. It's got to be really small. Like,
right. Well, at this point, I mean, I'm not sure what the vetting process is, but the list is the list. You are supply limited because your staff, your doctors, your partners, they've been fit tested. They have their size. It's a matter of having the supply.
Yeah.
So let's talk about then. I don't know what the size of your clinic is. I don't know how many operatories are. I don't know the layout. I don't know if the infrastructure, if there are enclosed operatories or if they're more of the typical dental surgical suites. But now you know someone is coming. Let's say you have N95s. Okay, there's a lot in this question.
Yeah.
Are you keeping up?
I'm keeping up.
You got N95s. You've got a definite emergency case. Somebody who's screened positive. You've got your nurse, dental assistant. You're there. You're going to do this surgery. Who else is in the clinic? And what other things are you taking into account? Because you're going to be creating aerosols.
Yeah.
We don't know. There's a lot of unknowns still. There's a lot of experts saying that it's not aerosol spread. There's a lot of people saying it could be. Let's be careful.
Mm-hmm.
So what are you thinking about in your clinic now that's a little bit different?
So again, getting back to who could actually properly wear an N95 mask is if I had a patient who really needed active treatment in the office, it would be me and one of my partners who's been appropriately tested, as long as we have the appropriate masks in that room.
Okay.
And it probably wouldn't be any of our assistants or nurses because, again, none of them have ever been mandated to be tested, so none of them have been tested.
Right.
The other problem is, when a patient like this shows up really sick at the hospital, sick from the virus, they're put into negative pressure isolation rooms.
Right.
There's no dental office that I know of in the country, maybe in the world, that has negative pressure isolation rooms.
Okay.
So there's sort of a whole
Explain
host.
Negative pressure for the layperson.
Oh, no.
Not everybody.
Oh no! It means nothing's getting pushed out of that room.
Good. Okay.
Right? That isn't filtered. Right? So it's all filtered within the room. And for those of you who actually know what it means, and if I'm wrong, you can't hold it against me.
You can reply.
But I know it's a rarity.
Comments.
I know it's exactly. I know. I don't think anyone has.
But the idea is that if there's virus in the air, it's not coming out of the surgical suite.
Right.
That's the basics of it.
So we're fortunate in the way we're operating now is out of our 3 offices, we're opening 1 office at a time on rotation. So today it would be maybe our office in Toronto. Mm-hmm. Tomorrow it'll be our office in Aurora, whatever it is. Mm-hmm. And there's lots of rooms at each location. Right. So in a situation like this, what I would do is that patient would only be treated when there's no other patient in the office.
No patients.
Right?
Okay.
That room that they're treated in would be as far away from any other treatment room that we have. Right. And as far as cleaning it afterwards and appropriately wiping it down, that would probably be. I don't know that I'd even want to put that on my nurses or assistants to do. I think after I was done, I would probably be the one who would want it, because again, the whole point is reduce contact points, reduce the number of people
out in the community and spread it. And then,
But it's a tough one. And as we're sitting here talking, and this is probably happening to everybody,
who's thinking
you
about
think of
this.
the next scenario, right? And oh my God, I haven't thought of that scenario. Now this is a whole, and probably at all levels, right? Regulatory levels, all levels. There's probably new things that are coming up minute by minute, hour by hour, how we
Yeah.
deal with these patients. Anyone with a severe issue, I would probably then revert down to hospital.
Mm-hmm.
And we should talk about how that should happen.
Okay.
When you're ready.
No. I think so. So a lot of my questions have been answered. But my overarching concern is, you're not the only one. You're fit tested, and you can't get N95s in private practice. B, there are a number of dentists who've never been fit tested, 90-something%, I'm going to guess. And in terms of dental assistants, it's higher. It's been a few days, but infections now that aren't an emergency today, maybe in a week.
Yeah.
On top of that, people are going to delay treatment, and then they're going to realize, finally, I need it, whatever the treatment is. I'm not sleeping because of the pain, whatever the case may be. And there are going to be specialists and general dentists who just can't treat them. The other thing that's going to happen, from what I've been hearing, is the number of people with COVID-19 is going to increase exponentially. Yeah. Therefore, the people who've been in contact with those people is going to increase exponentially. And the people screening out of the general dentist or even private practice care is going to get smaller and smaller. The emergency cases are going to get larger and larger.
Yeah.
I don't know what the long-term planning is for hospitals, but at some point, like what is your, if you're a politician, let's turn you into a politician now. What do you want to see over the next 3 weeks, month, 2 months to ensure that we're not turning true dental emergencies away at the ER where they're dealing with other issues? How do we approach this problem?
I think it's twofold. I think if a dentist, whether they be a specialist, an oral surgeon, general dentist, endodontist, has an emergency that they can't, for whatever reason, handle either by telemedicine or by non-surgical or non-interventionally, let's say, then that would be an appropriate use of some of the other resources currently available, as long as everything stays relatively like it is now. If I'm sending a patient, let's say I'm an oral surgeon and I'm not an oral surgeon who works at Mount Sinai Hospital, but I needed to send a patient walks into my office with a facial fracture. So that's a patient that needs to be seen through a hospital emergency department. What public health is asking be done is that you don't just send the patient to the emergency department.
Okay.
You let the emergency department, and this, I think, should go on long beyond this crisis, is you, as a courtesy, let the emergency department know this patient's coming. Even more importantly, if it's a patient that fails active screening, let them know they're coming. If it's a patient who doesn't need to be seen through an emergency department, but for example...
Well, let's for a quick second here. So if the goal is to flatten the curve to social distance, and there's a patient who has a dental emergency who's failed the screening, them showing up the ER doesn't do a lot for flattening the curve.
Correct.
They're going to have busier and busier waiting rooms. I don't know if they're getting masked and their temperature's taken when they walk in, but last time I went to the ER with a broken toe, I wouldn't do that today, probably. I'd definitely call. It was very crowded.
Yeah.
And there were a lot of people in there that I can only assume were vulnerable populations to viruses like this. The last people, in other words, that I'd want to be around if I had any of those symptoms.
Yeah.
So I guess what I'm trying to get at is, are you concerned at all that eventually, if we can't get any more N95s, if the curve starts to get steeper, and these emergencies start to pile up, that eventually we're going to be sending dental patients to a place where they're not going to get the care they need necessarily, and where they're actually going to be around more people, not fewer people. I mean,
Yeah.
so I'm a risk manager. I don't know if I mentioned that at the beginning. So my mind tends to turn towards these eventualities. You're probably busy treating patients, maybe not, but have you had any thoughts about
yeah,
that?
absolutely. And part of the protocols that we put in place at the hospital were put in place to deal with that exact scenario. So the majority of dental emergencies
Yeah.
that aren't facial fractures,
Right.
severe infections, and uncontrolled bleeding, the stuff that before this
Right.
COVID crisis started would get triaged they'd show up at the emerge at the hospital, they'd get triaged
Right.
by a triage nurse, they'd sit in the waiting room at the emerge,
Mm-hmm.
they'd then sit in a treatment room till one of our residents came to see them. Those right away
Mm-hmm.
at the door
Mm-hmm.
are being redirected to our dental clinic
Right.
at Mount Sinai, not to walk into the dental clinic.
Right.
They're being redirected through a proper screening pathway.
Yeah.
If they screen positive, they
Yeah.
fail active screening, they're masked.
Right.
And then one of our residents, whoever happens to be on call, will be number one in contact with that patient.
Right.
Hopefully not face-to-face initially, hopefully by phone. We still haven't ironed out all the details to really triage them by phone. So is this something that I can manage, again, with some antibiotics
Yeah.
and some analgesics? Then I'm going to do that. And I'm going to follow up with them in
Right.
48 hours and
Yeah.
let them know if things get worse to contact us. If they need to be seen, the protocol is, again, reflective of social distancing. So
Right.
they're being appointed at very specific times, no two patients being appointed at the same time. And all the same protocols would be in place. So if this patient failed screening and they need treatment, COVID, I'll call it COVID PPE,
Mm-hmm.
would be in place in our dental clinic to manage those patients. But I think the goal is to keep them out of any clinic. And
Right.
so while I completely agree that, for example, a bad tooth, a tooth that's
Right.
infected and painful, the ideal treatment is in normal times, and even now, is source control.
Okay.
Endodontic treatment,
Right.
or remove the tooth,
Yeah.
right? Now it might be, I get that, but why don't we see, as long as you're not showing signs, symptoms of systemic infection,
Try something else first.
try something else first.
Okay.
See if we can get you over the hump.
Right.
And if we can't, then we've tried,
Yeah.
and then we go to the next step.
Sure.
I know Gary Glassman's going to talk
Yeah, on
about
Monday.
on Monday night, the hot tooth and what to do with
Yeah.
it. And we chatted today, and he's got some great insight. But it's also along the same lines, right?
Yeah. Try other things first. I
Yeah.
know I had an instance in my life once that I needed a root canal. I couldn't sleep at night, and I took Tylenol. I never take Tylenol. I took it around the clock,
Yeah.
and I still couldn't sleep. And you have to think, there's a lot of things to consider. One is what's going to happen to this person's immune system, social life,
Everything.
you know what I mean? All of those things down the road if we don't treat them. Well, I think we've been going for quite a while now. I have questions left, but I think maybe we can do this again sometime.
Anytime.
It has been an absolute pleasure talking to you. Thank you so much for sharing your experience, your opinions, your knowledge. I hope that the resources at your hospital continue to be able to meet the demand as this whole thing evolves. I hope, for the sake of, we didn't even get into all of the layoffs in dentistry, the economics of this whole thing in terms of paying for clinics to stay open, not knowing how long this is going to happen. Meanwhile, watching your investments tank.
I got to tell you, the hardest thing for my partners and for me and for probably most of the people watching was the calls to the staff to tell them we got to shut down for now, and for a very short period of time. Hopefully, people are out of work. I mean, that's And the only thing that I can say to that is that gets back to the social responsibility. And I would say people need to stay home.
Right.
They need
Do
to
what's
stop
right.
going out and stay home. Yeah,
Yeah.
and they need to do what's right.
Right.
And that's
Listen
why
to public health.
Listen to public health, and that's why for all of you guys, keep your offices running to manage emergent treatment and manage as much of it as you can, as I said, by phone, instead of having people come in. And that's the way we have to do this together.
Right.
This is unprecedented.
Yeah, and it's for our families, it's for our neighbors, it's for our communities, as well as our staff and our patients. We have to think about all of that in this time of unprecedented of crisis and also coming together. I think there's a silver lining in that people are staying home and they really are starting to empathize with not only their neighbors, but people they don't even know.
Yeah.
But the whole conversation about staff, about the community, I think might be another segment that we'll have in the future. Once again, Dr. Rittenberg, a true pleasure. Thank you so much. That's it from dentalcorp. Thank you again. This is Julian Perez signing off. And before we do,
elbow bump.
yeah, it was a real pleasure.
Good night.